You're listening to the Beyond Measurements and Image podcast, where we build healthier lifestyles, elevate your well-being, and transform lives. Welcome to BMI.
I'm your host, Dr. Drew Crawford. I'm a board-certified gastroenterologist and obesity medicine specialist. Thank you for joining me today on Beyond Measurements and Image. Today we're going to talk about the metabolic syndrome. The metabolic syndrome is a constellation of metabolic irregularities that occur in a cluster that seem to occur more often together. It's comprised of obesity, particularly abdominal obesity, where you just deposit the fat right around the abdomen, which we know is more dangerous. That's visceral adiposity. Additionally, insulin resistance is a key in the metabolic syndrome. And I know we keep talking about insulin, but it's just a recurring theme. And really, it seems like everything draws back to insulin. But what we know from obesity and the metabolic syndrome and all these is that it's a complex array of system. It's not just a matter of eating too much. It's the consequences that we face with a typical Western diet and the fact that we always have food available and that we eat essentially from the time we wake up to the time we go to bed. Not just 3 meals a day like we used to, but 3 meals a day plus snacks, plus sugary drinks. All this leads to elevated insulin and all of these abnormalities that occur hormonally. In the next few podcasts, I'm going to talk about cortisol and the role of cortisol in obesity. That's a steroid, but it functions in some ways as a hormone as well. So the metabolic syndrome is a constellation of metabolic irregularities that are characterized with the central obesity that we talked about, as well as insulin resistance, but also hypertension and hyperlipidemia, or elevated cholesterol, or particularly triglyceride levels. And why is that important? Well, if you have metabolic syndrome, you have an increased risk of atherosclerotic cardiovascular disease. So that puts you at risk for heart attacks and strokes, but also increases your risk for type 2 diabetes. Just like obesity in the United States and in Europe, there's been a significant rise in the risk of metabolic syndrome. And it's estimated that approximately 1 in 5 of all Americans and Europeans currently could carry a diagnosis of metabolic syndrome. What is metabolic syndrome? Like, how do you diagnose this? Well, it requires the presence of 3 or more of the following metabolic irregularities. So if you have a waist circumference greater than 40 inches in men or 35 inches in women, that's 1. If you have serum triglyceride levels of greater than 150, if you have a reduced HDL, which is high-density lipoprotein cholesterol levels, if your HDL level is less than 40 in men or less than 50 in women, that's a diagnostic component. If you have an elevated fasting glucose greater than 100, that's a diagnostic criteria. Or if you're hypertensive, if your blood pressure is greater than 130/85, or even either component. The top component of blood pressure is called systolic. The bottom is diastolic. So if your systolic blood pressure, the top number is greater than 130, or the bottom number is greater than 85, that's a diagnostic criteria. It's not that they both have to be up. You can see the metabolic syndrome is characterized when you look at these. The diagnosis of hyperlipidemia, because 2 of those are related to your lipid panel, right? Elevated triglycerides or low HDL. Remember, HDL is the good cholesterol. So if that's lower, that's a problem. And then a waist circumference greater than 40 inches in men or 35 inches in women, right? That's a marker of central adiposity or belly fat. And then, of course, the diabetes component, or the impaired blood glucose component, I should say, with a fasting glucose over 100, and then the hypertension. So remember, the metabolic constellation is central obesity, insulin resistance, hypertension, and hyperlipidemia. So it makes sense that these 5 criteria, if you have 3 of the 5, would put you at risk for metabolic syndrome, or would actually be diagnostic metabolic syndrome. So what are the common signs? Well, of course, the common signs are just that: increased abdominal girth, elevated blood pressure, and then signs of insulin resistance. So what's the cause of metabolic syndrome? Is it all just dietary related and lifestyle? Is it just from eating too much and not getting enough activity? And the short answer is probably yes. I mean, ultimately, it's much more complex than that. And as we know, there's so many hormones involved and all, but ultimately, it just kind of goes back to these dietary choices and lifestyle choices. Now, there is probably a genetic component, but there's just a lot of lifestyle factors. And then just eating a typical Western diet, we just know is not good. So what happens is you eat this typical Western diet that we've talked about before. You're not very active. And then you just get this buildup of fatty tissue, and particularly that fatty tissue buildup in the abdomen area, right? And around the organs. So historically, we thought that the way this worked was you had sort of insulin resistance. Your cells were resistant to the effects of insulin. Since the insulin wasn't working, your blood sugars were elevated, right? Because remember, the insulin is designed to drive blood sugars into the cells. So if the cells aren't sensitized to insulin, if they're not really responsive to that, what happens is the blood sugars rise, but then your body tries to compensate. And so it secretes more insulin. And so then you have an elevated insulin level, still trying to manage the blood sugar. But remember, insulin has all those downstream effects. It promotes the storage of fat and inhibits the breakdown of fat. So if you're running around with these elevated insulin levels because of insulin resistance, then what happens is you're just calling on your pancreas to make more insulin. Over time, your pancreas, particularly the beta cells, sort of wear out. And then when that happens, then you don't have enough insulin to manage your blood sugar and you end up with type 2 diabetes. So that's traditionally how it's been thought about. Now, there's an axis in our body called the hypothalamic pituitary adrenal axis. And it is a combination of effects of the hypothalamus in the brain that we've talked about that controls so much of these metabolic issues, as well as the pituitary gland, which secretes hormones. The pituitary gland then has effect on the adrenal gland. And that's particularly important in cortisol secretion. And I know as of yet, we haven't talked a lot about cortisol secretion, but we will in the coming podcasts. Cortisol has a big effect on all of this as well. There's some thought that the traditional model of insulin resistance ultimately leads to hyperinsulinemia, which then causes the beta cells of the pancreas to just kind of peter out and then ultimately ends up to type 2 diabetes. There's an alternative thought in the hypothalamic pituitary axis that maybe hyperinsulinemia comes first, which then leads to insulin resistance, which then leads to the beta cell dysfunction or exhaustion, which then goes on to diabetes. It doesn't matter. We don't need to get into the woods, but there's just some thought on that. But either way, what you got to know is that elevated insulin levels over time ultimately end up with insulin resistance. Which order that comes in is not entirely clear. And then beta cell exhaustion and then diabetes. So if you have these chronic elevated insulin levels, you've altered the energy balance. And so what happens is instead of the glucose or the energy being driven into muscles as a source of fuel, then what happens is with the elevated insulin levels, you just have all that energy going into the storage of fat. It's a little bit of a self-perpetuating problem, and it really just causes a lot of issues that ultimately make up this entire complex that we call overweight and obesity. So in addition to the buildup of all this abdominal fat and the insulin resistance, there's also a ton of what we call cytokines that are released, like tumor necrosis factor, leptin. Remember, leptin is one of the hormones that we deal with in obesity, adiponectin. And there's just a lot of them, resistin, plasminogen activator. There's a whole bunch of them. You don't necessarily need to remember any of those, but just I tell you this because it's important to realize that it's not just a lack of willpower, right? It's not just your inability to have self-discipline. Now, the irony of that is if you're able to gain the willpower and you're able to have the self-discipline and you cut these things out, right? You increase your physical activity and you decrease the calories that you're taking in. And maybe you work on the order of the eating, right? The order of the food that we talked about in the last couple of podcasts, and maybe even intermittent fasting. The irony is it's not just your lack of willpower or your lack of self-discipline, but when you actually are able to manage these things and control your diet and do these things, it actually does realign so much of what's going on in the hypothalamus and with all of these hormones. What are some of the risk factors that ultimately lead to an elevated insulin level in the first place? Well, again, we talked so much about the modern Western diet, but also there's probably a genetic component to this. And then remember, with hyperinsulinemia, there's definitely decreased clearance of insulin through the liver. And then with chronic elevated insulin levels, you end up with defects in the beta cells, which are what secrete insulin from the pancreas. And then you end up with this sort of loss of pulsatile insulin secretions, and you just have this sort of chronic elevated insulin levels. That being said, what is the biggest risk factor? Well, the biggest risk factor for the metabolic syndrome is visceral obesity, right? Central adiposity, a big fat belly. Not necessarily a big fat butt or fat on your legs or arms, but specifically belly fat, right? Visceral obesity. That's the main risk factor. And it seems to involve all of the pathways in the metabolic syndrome. And associated with that is a high calorie intake diet. The high calorie diet ultimately leads to the increased visceral fat, central adiposity, fat belly, whatever you want to call it, which then ultimately leads to all of these hormonal activities that go on in our body that end up with a metabolic syndrome. So how big a problem is it? Well, like I said before, it's estimated that in America and in Europe, about 1 in every 5 people have metabolic syndrome. So when you look at the NHANE study, right, that's the study that we reference all the time, the National Health and Nutrition Examination Study, the prevalence of metabolic syndrome has significantly increased from 25.3 to 34.2%. That was in 2012. Here we are 14 years later, and we know that it's up to about 20%. Also, this is happening in children. In 2020, it was estimated that 3% of children and up to 5% of adolescents were found to have metabolic syndrome globally. And it's a phenomenon that increases with age. So up to about 40% of people over the age of 60 have metabolic syndrome, and it's slightly more prevalent in women than it is in men. So again, why is that? Well, it's believed again that it's all diet related, right? Diet and lifestyle related. Everything that we do, all of the technologies, all of the new discoveries that come out, right, are all designed to make life easier and just to make us work less. Going from, walking to the horse-drawn carriage to the automobile, or a flight of steps to an escalator to an elevator. Everything is just designed to make life easier. But the reality of it is things don't have to always be easier. Psychologically and socially, that's great if we can make life better, but that doesn't seem to be the priority in society, right? It's what we can do to make things less physically taxing. If we don't have to climb steps and we can take an escalator, that's considered a win. But in reality, that's not considered a win. Combine that, right? Combine all the ease that we've built into our life, and then just a bad diet, right? We used to get up and make breakfast, and then it became easier to just have it in a cereal box. So much of that's not even real food. Definitely not like it used to be, right? Not like you had, bacon and eggs and toast for breakfast and a big hearty meal. Now it's more convenient. It's easier, right? You don't have to do as many dishes. You don't have to cook a big meal. It's less time consuming, right? Things just work toward being easier. And so instead you pull out a box of fake food, you pour it in a single bowl and you eat that, right? It's easier, but you've made a much less healthy choice starting your day. And then it just continues on throughout the day, right? Everything continues on in terms of poor diet and less activity. And that's ultimately what leads to the increased calorie diet, oftentimes the central adiposity, and then the cascade begins where the metabolic syndrome kicks in. So how do you know if you have metabolic syndrome? Well, when you go to your doctor, one of the things they'll do is they'll do an exam on you. And one of the physical signs that you see with insulin resistance is what we call acanthosis nigricans. And it's like this kind of a dark, velvety patch, oftentimes on your neck, kind of behind your ears. And that's a good sign of insulin resistance. Also, you can see xanthomas, which are like little deposits around the eyes, usually related to elevated cholesterol levels. In addition to the physical exam, your doc will want to draw some blood work. They'll want to check your blood sugar, and they need to do this fasting. We've talked about this on previous podcasts, but an elevated fasting blood glucose ultimately leads to a diagnosis of prediabetes or potentially diabetes. Or they can look at a hemoglobin A1C, which tells you your average blood sugar over like the preceding 90 days. They'd also want to check a lipid panel, right? It would check your total cholesterol, your LDL, which is low density lipoprotein, your HDL, which is high density lipoprotein. Remember, in the cholesterol world, HDL is good, so you want that one high, and you want LDL low. And then also triglyceride levels, and particularly triglyceride levels are really associated strongly with the metabolic syndrome. But they can also look at, your kidney function. They can look at some inflammatory markers. They can look at thyroid studies. It's interesting that hypothyroidism is associated with metabolic syndrome. And then hyperuricemia, uric acid, if you have elevated uric acid levels in your blood, they tend to be in patients who have just a chronic inflammatory state, which is consistent with the metabolic syndrome as well. So that's some of the blood that can be drawn. They can also look at like calcium scores, like coronary calcium scores. They can do a scan, stress testing, EKGs. All of these things just sort of look at the blood work that is associated with the diagnosis and then some of the complications, particularly when they're looking at these heart issues. So the crux of it here, what do you do? Whether you go to your doctor and get an official diagnosis or you just think you might have it and you want to start making changes to avoid it, what do? Well, the primary goal is just to get your diet and weight under control. Because remember, the biggest risk factor for all the things downstream of metabolic syndrome is central adiposity. And the risk factor for central adiposity is excess calorie intake. The first thing you want to do is identify whatever risk factors you might have. It is important to know if you have high blood pressure in particular, right? You want to get that blood pressure down. And oftentimes it's medications initially, but getting the weight down will help. If you have hyperlipidemia, elevated cholesterol, elevated triglycerides, right, you might need to be on medications for that as well, at least in the short run. But if you can get the weight off, oftentimes you can come off of those medicines. And of course, diabetes, right? If you have a diagnosis of diabetes, type 2 diabetes, you might need to go on medicine for that. Again, at least in the short run. But if you do go on that and you're able to lose the weight, oftentimes you can come off the medicine. So you see the common factor here is you lose the weight and so many of these other issues tend to resolve. Maybe not immediately, maybe not as quickly as you would like, but they can resolve. And it's interesting when you look at the GLP-1s, right? I mean, we know that initially that was a medication for type 2 diabetes, works very well, but also it has a side effect of weight loss, which is very beneficial in the metabolic syndrome as well. And oftentimes if you lose the weight, the diabetes could go away, so you could potentially come off of that medicine. Unfortunately, it doesn't always work that way, but it is kind of ironic to think that the drug companies may have actually made a product to treat a disease that the side effect is actually altering the body where the disease could go away. It's just hard to imagine that that was the intention of the drug companies, right? They like you to get on a drug and to stay on a drug long term. These are the lifestyle modifications that you can make. And then, of course, also just general healthy lifestyles, right? Physical activity, like we've talked about, 150 minutes. Healthy diet. If you're a smoker, don't smoke. If you're a drinker, minimize your drinking. If you can make improvements to your sleep, sleep better. I always ask patients to try to lose 5% of their body weight, right? If they come in and they weigh 300 pounds and I say, listen, you need to get down to, 170, right? That is an overwhelming request. And even though 170 may be the ultimate goal, if I say, let's just start with 5%, just 5%. So 5% of 300 is 15 pounds. Let's say over the next 6 months, work on losing 15 pounds. And so if they start doing that in 6 months, if they've lost 15 pounds, the reality of it is it may not show, right? They may not be able to see it, but they can probably feel it. Other people probably can't see it. So they're not going to be getting a lot of kudos for what they've done, but they'll know. It tends to be a slippery slope. And so if they get to that 15 pounds and they feel a little better and the things that they're doing to get them there are working, then oftentimes they're agreeable to continue on, right? And that 15 pounds then turns into 30 and then 100, and you see how that goes. It's like when you toe the line for a marathon. You're not thinking in that first mile about the 25th and 26th mile, right? You're just running the mile you're in. And so I tell the patients, when you're 300 pounds, you're just running the mile that you're in, which is let's knock off 15 pounds. When you run a marathon and you've knocked off 1 mile and you have 25.2 to go, you don't feel like you've done anything. It doesn't look like you've done anything. Anybody standing on the sidelines watching can tell you haven't done anything. They see the 25.2 miles ahead of you and know what you've got in store. And the same's true if you're obese and you're 300 pounds and you're on that 15-pound weight loss. You're in the first mile. Everybody looks at you. They see the 25 miles ahead of you or the 285 pounds that you're still carrying, right? That's what they see. But you know that you've knocked off a mile and you know that you can do it. And you know that you've got another 25.2 or another 100 pounds to lose, but you just stick to it, right? You just keep running foot after foot. You just keep running that race and eventually you get there. In terms of physical activity, if you're 300 pounds, I'm not recommending that you run a marathon, but you want to participate in 150 minutes of moderate to intense activity or 70 minutes of high intensity activity each week. You want to have a diet that's, basically composed of whole foods and less processed foods. If you need to, like I said, talk with your doc about treatment for high blood pressure, high cholesterol, and diabetes, at least initially while you're working the weight off, and then you might be able to work your way off of those medications. If it's severe, if the obesity is severe, you could always talk to your doctor about bariatric surgery, which I know we haven't talked a lot about, and I'll put together a few podcasts about bariatric surgery, but they are good. They're becoming less prevalent because of the advent of GLP-1s. But I just think if you can manage this, which most people can, if you can figure out a way to get the weight off without having surgery, in the long run, it's better. And what I mean by that is there's just less complications. They don't have to cut you open and rearrange everything on the inside. Now, when you look at the statistics of a gastric bypass, right, it does have very compelling data in terms of management of diabetes, weight loss. But I see so many people with complications from that. Now, I don't see the ones that don't have complications, so I have a skewed view, but there's stricturing of where they've reconnected things. there's just a lot of issues. A lot of people develop an iron deficiency anemia over time because you've bypassed the part of the small bowel that absorbs iron. So then, a portion of these people are in getting iron infusions because they can't take oral iron to correct that problem. If they could take oral iron to correct the problem, they wouldn't have the problem in the first place. Because if you take an iron pill, you've still bypassed the area where that would be absorbed. These patients have to go in and have an IV started and have iron infused periodically. In the long run, some of the additional things that you have to do in life, some of the complications that you might have and maybe getting iron infusions, is that maybe that does outweigh the risk of just being morbidly obese for years and years and years and all of the consequences of that. But alternatively, if making small changes, altering the order that you eat food, the hours that you eat the food that you eat, the quantity that you eat, if you just make those little changes over time and you increase your physical activity and you're able to avoid all of those types of surgeries, that's a better option, I think. It's not always the best option for everybody, but it's a better option. Back to the metabolic syndrome. Well, why is it important? Well, if you have metabolic syndrome, you have a 2-fold higher risk of cardiovascular disease and you have a 5-fold higher risk of type 2 diabetes. It's really important that you recognize that if you have any of these, that you start to get them under control, right? Even if you don't have the whole constellation of symptoms, remember you have to have 3 of the 5 that we talked about. But even if you just have one, go ahead and start with it, because we know that patients with metabolic syndrome, so many of them go on to develop heart disease, which means heart attacks and strokes, microvascular complications, right? The small vessels in the eyes that you see in diabetics, right? That's why diabetics go blind, right? Those small vessels get obliterated. Small vessels in the legs get obliterated. So there's a lot of amputations. They have kidney problems, and so they end up on dialysis. So all of these obesity-related complications just are self-perpetuating. They end up with sleep apnea, which in turn then elevates cortisol levels, which we'll talk about that. But that is as detrimental as the hyperinsulinemia. And actually, they may kind of go hand in hand, right? These elevated insulin levels, even though there's a component of insulin resistance, you wonder if the insulin levels are high, why is the blood glucose not low, right? It should be. And you can say, well, it's because of the insulin resistance. And you're probably right. But also, there seems to be an antagonistic component of cortisol that might kind of work its way in there in this whole process that elevates the level of the glucose. So what are the ultimate goals? Well, the ultimate goals is just a healthy lifestyle, right? Work on weight management. Try to get your BMI down to a healthy goal. Increase your physical activity like we talked about. 150 minutes a week is what's recommended. Improve your diet, right? A whole foods diet as opposed to ultra-processed foods, at least to the extent that's possible. And like we've talked before, it doesn't have to be 100%, right? If every time you make a food choice, or at least, most of the times you make a food choice, you just make the better choice, that's a step in the right direction, right? It's not like you have to go clear out your pantry today and eat perfectly, because nobody's going to do that. Alcohol. If you can avoid it, you're probably better off, but definitely if you can avoid it in the evening hours, it definitely affects your ability to sleep, right? Alcohol definitely affects your ability to sleep. And you say, well, gosh, if I drink enough of it, I sleep really well. Well, that's true. But if you don't pass out, right? If you just drink a little bit, it does affect your sleep. And then when you have sleep deprivation, again, you end up with elevated cortisol levels. So you can see we're headed towards some discussions on cortisol. So I think that's really about all I had for the metabolic syndrome. I think it's a pretty fascinating constellation of symptoms that you really don't want to have. It's interesting how it's just a cascade, right? It's a cascade that really starts and ends with obesity and the management of obesity. If you have any comments or questions, feel free to hit me up. I'm looking forward to hearing from you. In the near future, we'll talk more about cortisol level, which actually factors into the metabolic syndrome, although not directly. But it's all part of the same process. And what we know is that everything in medicine is so tightly interconnected. In Western medicine, we just separate everything out. You see the gastroenterologist or the cardiologist or your primary care physician or an endocrinologist. And it's almost as if, we treat them like they're all independent systems. But the reality of it is it's all one big organism. It's all one system. And everything you do that affects one component has a downstream or sometimes an upstream effect on other parts of the body. That's all I have for now. Thanks for listening, and I'll see you next time on the BMI Podcast. I'm your host, Dr. Drew Crawford. Join me next week as we go beyond measurements and image to build healthier lifestyles and elevate your well-being on the BMI Podcast. See you then.